Sure. So for those of you who don't know me, I'm Chris Elliott. I'm a physician right across the street over at Valley Medical Center. I'm a urologist. I once upon a time moved to California in 2004 to do my urology residency at Stanford. I stayed there and did a fellowship in female pelvic medicine and reconstructive surgery, which doesn't sound like it has a whole lot to do with spinal cord injury, but we're probably the urologists that understand complex fluid dynamics more than anyone else. So when they hired me at Valley Medical Center to do a lot of the reconstructive surgery on the female side, they also wanted me to get involved in the spinal cord injury program. Not only spinal cord injury, but MS, stroke, everything else that kind of strolls through Valley. So I've actually kind of gotten a ton of on-the-job training in addition to whatever I learned during my fellowship. I probably learned 3 times as much just during my 4 years at Valley. I gave a talk last year about reconstructive options for bladder management for persons with spinal cord injury, and it was very well received, but almost all my questions were about UTIs. So I realized very quickly that that's really what the audience wants to hear about. So this year when they asked me to speak again, I think I have a topic that will be a lot more interesting to the audience, or at least try to answer some of your questions. So without further ado, we'll get started. Uh-oh. Robert, I broke it. Hold on, everybody, 1 second. It was looking so good until I hit a button.
Let's see.
I think it's just out of presenter mode somehow. I think I just hit the wrong one, but
There you go.
you fixed it. Thank you. I just bought a Mac, so maybe I'll be better next year by the time I...
What is going on?
Oh, you fixed it.
Okay, so
Cool.
this is
Yeah, thank you. It should make it even bigger. All right, sorry about that. So a caveat before we even get started tonight is that studies of urinary tract infection, even in the general population, are extremely flawed. A lot of times no cultures are done on a lot of patients that get seen. Often bacteria are not the culprit. Other things can cause similar symptoms to urinary tract infection, like frequency, urgency, burning of urination. That can be like interstitial cystitis or painful bladder syndrome, which affects about 0.5 to 1% of the population. Urge incontinence, which is just overactive bladder, which can be mistaken. Vague flank pain, which a lot of people attribute to kidney infections, even in the absence of fever or any positive urine culture. But there are a number of patients that just get diagnosed with this all the time in the emergency room who've never really had a true documented urinary tract infection. And then cancers sometimes can kind of play havoc on the bladder. And kind of mimic urinary tract infections. At least once or twice a year, we actually get someone who's been treated for a urinary tract infection 5 or 6 times, never really got better, and then we find they have a cancer of their bladder. So it's always one of those things that we're very careful about. So studies in the spinal cord injury population of urinary tract infections are even more flawed, and that's because it's a hard diagnosis to make in a spinal cord injury patient. There's a lot of confounding factors. So in non-spinal cord injury patients, bacteria in the urine is uncommon. It's not supposed to be in there. It's supposed to be a sterile environment. But with spinal cord injury patients, this isn't always the case. A lot of bladder management is done through intermittent catheterization, indwelling catheterizations, even some people using common catheters, but with really high residuals. So once they get a bacteria in there, it's really hard for them to clear that. One of the defense mechanisms against urinary tract infections in the kind of quote-unquote physiologically normal bladder is just the fact that multiple times a day the bladder gets completely flushed out. So there's kind of a cleansing effect where bacteria are not allowed to set up shop. So also, in addition to the fact that it's a hard diagnosis to make and there's more bacteria in the urine, urinalysis, which is, your dipstick, you pee into a cup, they come back, oh, you have a UTI. Well, it's not very good in spinal cord injury patients. If you're catheterizing yourself multiple times a day or you have a catheter indwelling, that catheter is going to cause some irritation. So you're always going to have some white cells in your urine. You might have some nitrates if you have just chronic bacteriuria, So bacteria always in the urine, regardless of whether it's really bothering you or not. The two most common things we use to diagnose this on a dipstick, they're usually wrong, or they're not specific to a urinary tract infection in someone with spinal cord injury. So they're not sensitive, they're not specific. So, and the symptoms of people with spinal cord injury are all over the board. Some people get autonomic dysreflexia. Some people have new or increasing spasticity. Some have new or worsening urinary incontinence. Some have back or abdominal pain, and some have foul-smelling urine. And none of these are really great predictors because there's a million other things in a spinal cord injury patient that can cause each and every one of these. So it makes it really hard. You almost have to use it it's almost a diagnosis of exclusion sometimes. Like, we can't find anything else, so we're going to treat you for a urinary tract infection. But I try to tell my patients this all the time, that if you go to an emergency room, even if you chopped off your arm, instead of, just reattaching your arm like they should, they're always going to check your urine, and they're going to start treating you for an infection instead of just sewing back on your arm. And you could be having the best day of your life from a bladder perspective and the worst day of your life from an arm perspective, and you're going to get treated because people are not used to seeing bacteria in the urine all the time, and they're not used to seeing urinalyses work the way they do in spinal cord injury. And they don't really teach this in medical school. I think a lot of patients just assume all doctors know everything. They don't. And they're not used to seeing people with this sort of condition. It's a rare condition. There's only, 11, 12,000 new spinal cord injuries a year. There's only, 200 some odd thousand spinal cord injury patients in the United States, altogether. So you're talking about a very rare condition when you talk about everything else in the population. People are not very good at it. So even spinal cord injury patients themselves are not great predictors of when they have urinary tract infections. And I know there's caveats, so don't get mad when I say this, but there have been several studies of PM&R doctors who have looked at patients coming in complaining of spinal cord injury, and they use fairly specific criteria to actually diagnose a UTI, but they were pretty broad. You had to have 100,000 colony counts in your urine, and you had to have at least one symptom of a UTI. And even patients with this kind of broad application were only right 66% of the time. So one-third of the time, the spinal cord injury patient was wrong. There was something else going on, but they were attributing it to a UTI. Another group did a similar study and showed it was 60%. So in the ballpark, two-thirds are right, one-third are wrong. But when you talk about a very prevalent condition, you're talking about a lot of people who might get treated for the wrong reasons and be treated and not really get better from what's actually bothering them. So, again, my caveat is some people are more reliable than others. I have certain patients who, when they come in once a year for their UTI, they probably are having a UTI. I have a lot of people who are coming in every month with UTI, and I start to get very skeptical that they're having a UTI every single month. So we'll kind of go into that. And lastly, doctors and researchers are to blame for the problem that we don't have great research, because there's a study that was just done out of Michigan last year, which I got the pleasure of kind of being on a podium when they were talking about this. They looked at the 315 studies that are out there of spinal cord injury and urinary tract infection. 11 different definitions of urinary tract infection were used in those 315 studies, and only 55% of the studies, so 150 of these lacked any definition of any sort when they actually looked at the study. So how are you even supposed to know if it's a real UTI if you don't even have a definition? You at least have to start with a definition. And if you look at it, everyone's using different definitions, and we need to at some point come to some sort of consensus what it might be, just so we can improve our research going forward. If you have bad data going in, you're going to get bad data coming out, and you're not going to be able to help people. So the outline of my talk tonight is, what is the risk of UTI in someone with a spinal cord injury? What are the risk factors for getting a urinary tract infection? What's the workup of recurrent urinary tract infections? When you're getting more than 1, 2, 3 a year, what should we start doing? What are the common conditions that can confuse us and maybe act like a UTI but might be out there and do something else? And what are the treatment and prophylaxis strategies? And that's probably what everyone's interested in the most, so I'm going to spend the most time on that. So the risk of urinary tract infection and spinal cord injury, again, we don't have great data because nobody can come up with a consensus, but if you just look at spinal cord injury patients and what happens to them in the first year, forget if the doctors are right or wrong. On average, it's the most common problem in the first year after injury. Over a third of patients go to an emergency room or get hospitalized with this. 42% of all patients after spinal cord injury in the first year are readmitted to a hospital, and the most common reason for readmission is a UTI. And it's estimated that there's around 2 to 3 urinary tract infections per year in the spinal cord injury population. This is first year, second year, lifetime. You're expected to get 2 to 3 per year, be treated for 2 to 3 per year. Obviously, there are some people who don't get any UTIs on a regular basis. They can go a whole year, nothing. There are some people who are being treated 10 times a year for a urinary tract infection. So what are the risk factors? Number one is chronic colonization with bacteria. You always have bacteria in your urine. And why is that? Because when you catheterize, you have an indwelling catheter, 98% of the spinal cord injury population has at least some bacteria in their urine at any given time, unlike the general population, which is generally expected to have none. Those with indwelling catheters, by 2 weeks, if I put an indwelling catheter myself, 2 weeks from now, I would almost 100% of the time have bacterial colonization in my bladder at that point. There's nothing you can do to stop it. It's going to happen. But just because you have bacteria in something doesn't always mean it's a problem. I have bacteria in my ear all the time. That doesn't mean I have an earache. There are kind of balances of everything in life. So those spinal cord injuries patients that void without instrumentation are the lowest. There's a very select few spinal cord injury patients that can void volitionally on their own. They have the lowest risk, but even they are not without risk. Suprapubic tubes, indwelling fluids have the highest risk of bacterial colonization. Patients that are doing intermittent catheterization, sorry, I didn't spell that right, are somewhere in between. Condom catheters and volitional voiders are the lowest, but they're even not at zero. There's a finite risk for those populations. And you also have to remember that not everyone with bacteria in their urine gets UTIs. I just told you that almost everybody has bacteria that has a Foley catheter, a suprapubic, or is doing CIC, but not everyone is getting treated for a UTI every single second. So there's something else that goes with it. So, and like I said, I have lots of patients that they don't ever get a UTI. They're 30 years into their spinal cord injury. They've had maybe 1 or 2 in their entire time. So there's something else beyond just that causes it. So what are the other risk factors? Bladder pressures. We all know that, or we should know at this point, that a lot of people with spinal cord injury have bladders that are kind of not relaxed all the time like they should be. They're trying to squeeze all the time without the patient's permission. And these high bladder pressures with chronic bacterial colonization are an increased risk factor for getting UTIs. They either drive the bacteria into the tissue or they drive them up to the kidneys, and they're set up for lots of infections. I have a number of patients that this is a real issue, and people are publishing papers that, Botox injections in the bladder decrease risk of UTI. Well, Botox doesn't do anything to the bacteria, so they're clearly not fixing it in that regard. They're fixing the bladder pressures, and that's what's fixing the problem. So bladder pressure is a big one. If we don't have your bladder kind of under control, you're at much higher risk of urinary tract infection. So that's why a lot of people are on oxybutynin. That's why a lot of people are on mirabegron now. That's why some people are getting Botox injections. Not only does it help with your continence, but it can decrease your bacterial rate, your susceptibility to a bacterial urinary tract infection because it decreases your pressure. There's also individual susceptibilities. There's just some people who are more prone to urinary tract infections than others. We all know, the female out there that 5 or 6 times a year is getting a urinary tract infection. She doesn't have a spinal cord injury. She doesn't have bacteria in her urinary tract all the time, but she gets a lot of infections. And then there are other women who never get an infection. There's some sort of difference. And a lot of times there's thought to be familial genetics that play a role in this. People haven't made a lot of associations other than they kind of run in families sometimes. But as we figure this out better, I think we'll have better management strategies to try to decrease the risk of UTIs in a lot of people if we can figure out what's causing them. It also depends on the type of bacteria you're colonized with. Some bacteria probably are much more likely to give you an actual clinical infection than other bacteria. And we'll talk about this a little bit in some strategies that people are using to try to prevent UTIs. But these are all things that kind of play into it. So if someone keeps getting urinary tract infections when they come to see me, here are the things that are going through my mind. You can get a peek inside my brain. First, I'm going to look at what kind of bacteria are you infected with. If it's the same bacteria over and over and over and over and over again, same antibiotic susceptibilities, same exact organism, That leads me to think one way. If it's a different organism every single time, well, then I start to think about it differently. So if it's the same bacteria over and over and over again, that's called persistence. If it's a different bacteria, that's just reinfection. You're getting infected with a new bacteria each and every time, and there are profound differences in how you think about these things. If it's a persistent infection, there might actually be a source inside the patient's body that's kind of the cause of this. We get rid of the UTI, a couple weeks later it comes back because we never really got rid of the source that caused it. If it's reinfection, well, maybe there's just something in the patient's kind of lifestyle that we can modify. So for persistence, I'm usually going to get some imaging, but I like to get imaging in everybody every year anyway. So I'm usually getting an ultrasound. I might get a CT scan if I'm really suspicious for a stone or something that might be causing something. Sometimes I even just get a plain x-ray. It depends on my mood and it depends on how I'm thinking about that situation in that particular patient. Sometimes I'll do cystoscopy, sometimes I won't. It kind of really depends on the situation, what I'll do. I don't do a ton of cystoscopy for routine infection problems. I generally will get imaging first because I think it's somewhat easier for the patient sometimes to do. And we're generally getting it on a yearly basis anyway, so I usually have kind of a baseline to look at there. What's that?
What is
cystoscopy? I'm sorry. The question is, what is cystoscopy? And the answer is looking inside your bladder with a scope. So a direct look directly inside your bladder with a camera. You get to see it, I get to see it, we all get to see exactly what's in there. Is there some sort of something in your bladder that's causing this, like a stone or something else like that that could be causing this? A lot of times I'm going to get urodynamics on a patient because it's going to help me learn something about their bladder pressures. It's going to let me get an idea of what the patient can hold before their bladder pressures get high. And concomitantly with that, I'm going to get what we call a voiding or a catheterized diary. So for a day or two before the patient comes see me, I just say, do what you normally do, but when you catheterize, tell me how much is in your bladder. Tell me how often you're going in between catheterizations. 4 or 5 times a year, I just find something the patient is doing wrong with their catheterization schedule or their drinking habits or something like that that totally makes it, all the puzzle pieces all of a sudden fall into place and you know exactly why the patient has what they have and you can modify that and you can just quit this cycle of just antibiotics, antibiotics, antibiotics with the patient never really getting relief from their condition. So here's a source. As you guys can see in the left kidney, it's all whited out. You see where does everybody see this? This is a very large kidney stone. This is a kidney stone that's been made by bacteria setting up shop in this patient's particular system, and they've made what we call a staghorn stone. So the bacteria is making certain factors in the urine, which makes certain factors precipitate out. It forms a stone. All the bacteria are living inside this giant stone, and as soon as we finish treating with antibiotics, well, the bacteria just come out of their little hiding place and reinfect the system. This can be in patients with spinal cord injury. This can be in patients that are just walking around the street, never had any neurologic insult. This is rare. Most small kidney stones are not going to cause this problem. It's generally the very large stones that would do this, something like a staghorn stone. Here we have a very large bladder stone. So this is a patient who was seeing me complaining of just, I can't hold anything, I'm constantly being treated with antibiotics, it gets a little bit better, but as soon as I stop, I get blood and I start peeing a lot again. I don't know really why antibiotics made this better, but their whole bladder is basically filled with a stone, so that kind of answered the whole question here as to what was going on with this patient. A simple radiograph found this. Yeah, we actually took this out open. It's a lot to do through a telescope. It would have taken me about 6 hours, and it took me about 45 minutes to do it, a small little incision and pull out the stone. This is rare. Most people do not have stones this big, and this is why I advocate getting an ultrasound of everyone's kidneys and bladders once a year. We catch these things before they get really big. This patient had not had imaging for about 6 years, and it had developed during this time, and they actually had risk factor. They had a history of bladder stones, so we should have been watching them a lot closer. So this is kind of what little stones in the bladder look like. So when you ask what cystoscopy is, this is what cystoscopy is. We look inside, you get a nice little view, you can find all kinds of little things. But again, most patients with bladder stones are not having recurrent UTIs. This is usually not the cause, but sometimes they're just another answer for what may be going on. So here's another source. So here's one of the patients I was talking about. So this guy came to see me every month and a half. He's being admitted to the hospital with pyelonephritis, fevers, UTI, leakage, feeling really crummy, They always grow something out of his urine. They're growing something out of his blood probably every other time he comes to the hospital. He's having fevers when he's being admitted. And everyone's at their wit's end, like, what are we going to do with this guy? So we did urodynamics, but when he came in for urodynamics, he brought in his bladder diary. And if you look at this, you can see that most of these volumes are much higher than what I would suggest for most patients. So usually I tell people 300 to 500 cc's is what you should be shooting for with intermittent catheterization. A little lower is fine. Get up to about 500 every once in a while, that's fine. But when you're doing it routinely on a multiple time basis like this patient is, every time his bladder is getting over 500 cc's, and I confirmed this with urodynamics, his bladder pressures really start to rise. So when he's got 1,000, 1,400 cc's in his bladder, his pressures are through the roof. And so any bacteria that's in his bladder is probably being forced up into the kidneys, and then he's getting all these horrible infections. So this is a guy who's essentially drinking 8, 9 liters a day of fluid, just because he was told by a doctor he should drink a lot of fluid to prevent UTIs. So took the doctor's advice, did a really good job of drinking a lot of fluid, but actually made his condition a lot worse and actually potentiated UTIs in himself. So we got him back under control, and he's had like 1 UTI in the last year since starting to drink normal volumes. And all I had to do was kind of educate, hey, look, a normal bladder holds 500 cc's. A normal spinal cord injury bladder holds 500 cc's. You're not meant to hold 1,400 cc's. That's a bad situation. He thought it was kind of cool he could hold so much. I told him, you can do it, but it's not a good situation for you.
Excuse me.
Yes?
We use the term UTI a lot to say that there is no definition.
Oh, sure.
To me, the fact that the bladder has bacteria means you have an infection. So can you find UTI before you use that term over and over?
Yeah, it's really hard because, like I said, the question is, I'm using the word UTI over and over again, and I said the definitions are good. Well, at some point, I have to say, a UTI is you have bacteria in the urine, and the patient feels lousy, and they have symptoms, and our culture will show more than 100,000 of certain bacteria in it. That's kind of the only definition I have at this point in my life. It's not a perfect definition because there's lots of people who have over 100,000 colony counts of any bacteria, and maybe they have symptoms, but maybe those aren't really due to the bacteria. I really struggle with this on a day-to-day basis. Medicine is more of an art. It's not a cookbook all the time. So I don't have a perfect answer for you, but these are patients seeing me for what they term recurrent urinary tract infections, and it's my job to try to figure out, is this really bacteria in the urine causing this, or is it something else that we're not figuring out? And if it is bacteria in the urine that's causing this, how do we get rid of it? But I don't have a perfect definition, to be honest with you. Again, I think if people are over-descending their bladder on a chronic basis or the pressures are through the roof, even with normal volumes, but the pressures are really high, I think you drastically increase your chance of having a urinary tract infection. So here's a different source. So this patient came in to see me. Every time, multiple times a day, he has pain at the tip of his penis, and he says, that's a urinary tract infection, because every time I go and complain of it, they catheterize me, they tell me I have bacteria in my urine, and they give me antibiotics, and maybe I get a little bit better, maybe I don't, but they just keep treating me. So we did urodynamics, and as soon as this started happening, you can see all these little wavy lines where the arrow is. That's his bladder squeezing like crazy, and he's actually sensate enough to where he feels the bladder spasm pain. That's how most men perceive bladder spasms when they're not spinal cord injury. They have pain in the tip of their penis. That's exactly what this gentleman had. And as soon as this started happening, he goes, yep, I'm having the UTI symptoms right now. And I said, no, you're not. You're having bladder spasms, and this is what's causing this. We put him on Myrbetriq and oxybutynin, and the symptoms have gone away. He hasn't had any UTIs in the last year. So a lot of things can mimic what patients are being told are urinary tract infections by other doctors, but again, they're underlying causes. So again, patient just misinterpreting signals. Common other confusing conditions. We talked about bladder stones. We already looked at that impressive x-ray. Bladder contractions. We just looked at that. Autonomic dysreflexia. Well, there's a lot of reasons to have autonomic dysreflexia. It is not just always bladder infections. Your bladder can be overfull. You could have bad constipation. You know, you could have some sort of injury to your lower extremity that you don't know because you don't feel it. You could have like a broken leg. I've had people come to see me for recurrent urinary tract infections, where they were found to have a broken leg. Their body was trying to tell them something was wrong, but nobody could figure out what it was, and they just kept blaming the bladder. Other nerve-related pain in the body, spinal cord injury is an injury to the spinal cord, and the spinal cord, a lot of nerves. If those nerves start doing what they're not supposed to do, and they start to fire off, and the patient perceives that as pain, a lot of times it's, in the lower abdomen. Don't ask me why. Maybe that's why they're seeing me, because their pain was in the lower abdomen. But it gets misinterpreted as a urinary tract infection when, in the end, it's probably just some sort of nerve firing off causing pain, because most of those patients tell me, yeah, I take all these courses of antibiotics. It never really helps my condition. Well, then maybe we should be looking somewhere else. It's a difficult situation, though, in these particular patients. Constipation can cause this. A lot of people get autonomic dysreflexia when they have constipation, and it can very often be confused with urinary tract infection. Dehydration can also cause this, and then fluid overload, as I had showed you, that gentleman's cat diary, where he was drastically overfilling his bladder multiple times per day. So now we're going to talk about treatments, and that's why everyone's here, because they want to know, what can I do to decrease my risk of a urinary tract infection? So I'm going to show you a lot of studies, and it's all going to be somewhat disheartening, but I promise there's a light at the end of the tunnel, so bear with me. So people have done some studies looking at daily irrigation of either suprapubic tubes or through the intermittent catheterization just to wash out the bladder with saline. It doesn't really seem to affect bacterial colony counts in the bladder, so it doesn't, just doing it once a day doesn't seem to rinse out the bladder no matter how hard a patient might try. It's also thought that this doesn't really reduce your risk of urinary tract infection. It may reduce your risk of forming bladder stones and other things like that, so that it's a good practice from that standpoint. But as far as decreasing your risk of infection, people have not been able to show that in studies. Daily irrigation with either acetic acid or GU irrigant. GU irrigant is neomycin and polymyxin B, which is kind of an antibiotic preparation that I actually do prescribe this for patients because I do think it helps to a certain degree, but it doesn't seem to affect bacterial colony counts in the bladder. So it doesn't get rid of all the bacteria in your bladder, probably because we can't do it often enough for the patient. Increasing urine production, so just drinking a ton of fluid to try to wash everything out. That doesn't seem to work on multiple studies that people have done. Changing indwelling tubes on a fairly frequent basis, doing perineal washing. I have some patients that are putting like bleach all over their genitals, trying to decrease the risk of urinary tract infection. It doesn't really seem to help. To a certain extent, I tell people, look, you just have to live with this risk. Like, you can't get rid of bacteria. And to a certain extent, if you get rid of all the bacteria in your body, other things are going to take their place, like fungus and other things that you don't want on you. So you got to be a little careful with what you do. And sometimes you can wipe out all the good bacteria, and you can let a bunch of things that you really don't want growing in your bladder on you. So again, we have to be a little bit careful. But none of these things has been shown to decrease bacterial colony counts in the bladder, and they also have not been shown to have a huge effect on urinary tract infection incidence in the spinal cord injury population. So what about antibiotic prophylaxis? Because, there's a number of patients on there taking a daily antibiotic to try to rid their system of bacteria. In the short term, it's actually been shown in multiple studies that you can decrease your risk of a symptomatic urinary tract infection by taking a daily prophylactic antibiotic. That's either Septra, nitrofurantoin, Keflex, even Cipro. The problem is, in the long term, I think unless you have just an atrocious problem that I can't come to a solution for, I think it sets you up for a lot of bad things. Number one, the medications themselves have side effects. No medication is without any side effect, especially if you're taking it every day of your life. Bacterial resistance generally develops. So a lot of my patients who are taking prophylactic antibiotics, when they do get an infection, generally that bacteria has found a way around it. Bacteria are smart. They find ways around things. And you have to imagine these things are multiplying millions of times a day. They can find their way around anything genetically given enough time. So generally when a patient does get a urinary tract infection on prophylaxis, well, now it's just resistant to that antibiotic, and that's one less antibiotic I can use to try to treat their symptomatic urinary tract infection. And again, you get resistant to enough antibiotics, well, pretty soon you're talking about PICC lines and IV antibiotics and big problems. So, and prophylaxis, as soon as you stop, your risk just goes back to baseline. So it only works while you take them. You don't get some sort of 3-6-month honeymoon period afterwards. It's the week that you're done, you're back to the same risk you always had. So I don't love these. If you look at some of the drug effects that some of these can have, long-term nitrofurantoin prophylaxis has been shown in some cases to cause pulmonary fibrosis. That's where your lungs don't expand or contract perfectly or adequately. You have trouble with oxygenation, and you can actually die of this, and it's an irreversible condition. So I don't let people stay on nitrofurantoin for more than a year straight because this risk tends to go up after that. It can also affect your liver, and it can increase your susceptibility to certain neuropathies. I always look at my spinal cord injury patients. They have enough nerve problems. I don't need to cause, nerve problems in their good nerves.
Is that a particular medication, or is that a family?
Nitrofurantoin is a particular a medication all unto itself. It's called macrobid or nitrofurantoin. Macrobid is to treat real infections, though often patients are placed on macrobid prophylactically by doctors who don't really understand the medicine. But it's just one class of drugs. The nice thing about nitrofurantoin, though, is it gets highly concentrated in the urine, and it doesn't affect the bowel very much. So you don't run the risk of Clostridium difficile, changing your normal gut flora, increasing your risk of diarrhea for other issues. So it's a really nice antibiotic to use, but it does have potential problems. And it's one of the favorites that people use for prophylaxis. Yes?
I've been taking it probably for 30 years.
Mm-hmm.
I shouldn't be taking it?
The question is, I've been taking it for 30 years. Maybe I shouldn't be taking it. I generally don't like it as a practice. I usually, if someone's going to be on prophylaxis, I like to switch nitrofurantoin and another antibiotic yearly and go back and forth because I think it decreases your risk. Now, the risk of pulmonary fibrosis, the risk of liver problems, they're all extremely low. These are safe things, but they're not impossible. So about 1 in 750 patients on long-term nitrofurantoin has some sort of problem enough to warrant hospitalization. This is an estimate. My guess is it's even lower than this. That's what I believe. But
I won't be here next month.
I didn't say that. I think a track record of 30 years generally speaks for itself in spinal cord injury.
Probably been longer than that, but
I find most patients that have been doing whatever they've been doing for 30 years, it's probably working, and I'm pretty loath to change anything.
well, every time I've gone to a different doctor, I always say, should I be taking this? And they say,
So the question is, I go to doctors and I ask, should I be taking this? Most people don't know about some of these side effects. I only know it because I prescribe these medicines a lot, and I get a lot of people who are on them chronically. But I don't know. It's hard to say that something you've been doing for 30 years is a bad idea if it's been working for 30 years. So as soon as I would change your regimen, you'd probably have a whole bunch of problems and you'd blame me. That's generally the way life works as a doctor. So we'll just leave it at that, I think. So Septra, or sulfamethahexazole, or TMP-SMX, as it's often known to a lot of patients, that can cause drug rash. In very rare instances, it can cause something called Stevens-Johnson syndrome, which is like a scalded skin syndrome where you can end up in the burn unit. It's a severe allergic reaction to the drug. It can happen. So, again, these things generally happen pretty quickly once you start the medicine, but I tell people if you get a bad rash, you need to stop this right away. Don't just keep taking it. I remember as a resident, we had one patient who I was not actively involved with, but they actually ended up dying of this horrible reaction. I mean, it's like a 1 in a million type of thing, but I saw it, and it kind of struck me firsthand that everything has its consequence, no matter how little you think it might be. And Septra itself can interfere with the metabolism of other medicines that you're on. It can increase the effects of Coumadin, which is a blood thinner, which is some of my patients are on. It can have effects that are unintended, and it can cause problems. So people have also tried, well, what about antibiotic-coated catheters? Just coat them with antibiotics. That'll fix the problem. Well, it works for about a week, and then the bacteria usually find their way around it, or your bacteria that are resistant to those particular antibiotics set up shop. So it hasn't been shown to work nearly as well as the catheter companies would have liked, because that would have been an easy fix, and doctors would have liked it too. So these are not recommended. In fact, I don't really know of many people that make them. There are a couple catheters that are out there that are coated in this yellow stuff, which I think is some sort of antibacterial. It's not an antibiotic per se. It's some sort of chlorhexidine or some sort of coating that's supposed to decrease the risk of infections. I don't know if it's really been shown all that well to work, but you know what? For certain patients, it's worth a try if you've got nothing else. Hydrophilic catheters. So a lot of people talk about like the speedy cats or the ones that are kind of self-lubricating. You just put water on them and they slide easily. You don't need lubrication. The catheter companies put a lot of money into making these things, and they did some trials. Almost every trial that's been sponsored that's shown a protective effect has been sponsored by the catheter companies. And it's interesting, for the 3-month endpoints of all these trials, a lot of them are actually positive. They had a decreased risk of infections, whether those were true infections or problems caused by people catheterizing with catheters that just weren't well lubricated. However, if you look at all these trials when they went out to 6 months, they didn't really see the effect anymore. So I don't really know what to make of that. If something's going to work, it needs to work long-term, not for 3 months. I think most of you are interested in things that work long-term, not for 3 months, and then kind of lose their effect. So I don't really know what to say about it. A lot of the catheter reps come up to me and tell me all my patients should be on this, and I'm kind of the opinion, whatever works for you, works. If you find hydrophilic catheters work for you, great. Fine, use hydrophilic. If you find using the same old Red Robinell and you use it for a year at a time and you just clean it in bleach and that works for you and you lube it up and it works fine, then that works for you. I'm pretty okay with whatever people want to do, as long as they don't drag their catheter like through the mud and then stick it in their bladder. I think they're going to be okay most of the time. So there's also something called methenamine, which some of you guys may know because it used to be used a lot in spinal cord injury patients. It's basically a non-antibiotic prophylaxis strategy. It's a chemical that in the urine, if the urine's acidic, is converted to formaldehyde. And that sounds terrible, but it's in such low doses it doesn't really do anything to the bladder. It's thought to potentially kill bacteria. Bacterial resistance to this has never been reported because it's not an antibiotic and bacteria don't seem to have their way around it. It may work better in patients that are on intermittent cath than in those with indwelling catheters because you may have more dwell time for this kind of formaldehyde to be affecting the bacteria, whereas with an indwelling cath, it may just drain out as soon as it's in there. But that's the case for a lot of the prophylaxis strategies. But today, it hasn't really been shown to be that much better than anything else. So here's a randomized trial done fairly recently where they put people on either placebo, they were on methenamine, or they were on cranberry tablets. And the percentage of people who were free of urinary tract infections at 6 months was kind of the same in every category. So whether you took a sugar pill, whether you took methenamine, whether you took a cranberry tablet, didn't really seem to be much of a difference. So I don't really know what to make of this trial other than it doesn't look like it works that fantastically. Cranberry itself, I know a lot of people last time I was here had questions about cranberry. Cranberry works because it's thought to decrease the binding of certain bacteria to bladder cells and to the cells that line the urethra, which will allow them to then crawl up into the bladder and set up shop. Generally, those are on E. coli and Pseudomonas, which are two of the more common types of urinary tract infections in the general population. But when you look at a spinal cord injury population or those with neurogenic bladders, there's a million other types of bacteria that can cause infection. So just affecting E. coli or Pseudomonas is probably not going to affect a lot of what people with spinal cord injury are infected with sometimes. So spinal cord injury patients may not do as well in spinal cord injury patients as the general population. So the thoughts on people with non-neurogenic bladders, so just, the lady out there that's getting lots of infections over and over and over again, there is some evidence to suggest that cranberry tablets or drinking a ton of cranberry juice may slightly decrease their risk. So I will put the emphasis on slightly decrease their risk. Most studies, however, find no association with decreased urinary tract infections. And in spinal cord injury patients, there's not a study to date that actually shows that supplementation decreases the risk of infection. Some of this is due to the fact that cranberry tablets themselves are poorly studied, and it's not like they're FDA regulated. Any company can go out there and make a tablet and tell you it's a cranberry tablet. There's differing levels of cranberry juice extract. There's just so many variables that go into this type of stuff because this industry is unregulated. So when people do studies, half the time we don't even know exactly what they are, and even if they found something that worked really well, can you go to the regular GNC and buy that particular cranberry tablet or something that works just the same? Well, the formulation is probably going to be different, so the heterogeneity of the system makes it very difficult. So, but to date, none of the studies that people have done have been able to show that these are highly effective. So I do have patients that swear by them, and I'm okay with that. There's also something I've recently been learning about because patients have been bringing it to my attention, something called D-Mannose. In vitro, so in the lab, it's thought to decrease the binding of bacteria to uroepithelial cells, so cells lining the urethra, cells lining the bladder. There's one clinical trial done to date. This trial was done, I think, in Croatia. I don't know what the medical research looks like in Croatia. I don't know how reliable it is, but actually they found pretty cool results. So they took people who were on D-Mannose, and they were drinking it with 200 mLs of fluid once nightly. They took people who were on antibiotic prophylaxis once a night, or they had a group with no treatment. And as you can see, the patients who had no treatment did drastically worse. And this wasn't a spinal cord injury study. This was just a regular, lots of women with recurrent infections. But 50% within 6 months had infection if they had no treatment. If they were on antibiotic prophylaxis, only 1 in 7 had a UTI. And those who were on D-Mannose had even lower levels of UTI, or again around 1 in 7. So the study wasn't blinded though, so everybody knew what they were taking. They knew if they were taking an antibiotic, they knew if they were taking the D-Mannose, and they knew if they were taking a sugar pill, because they didn't make everything look alike, which is a big problem in randomized trials, because placebo effects can have a big effect. Whether that affected this trial, I don't know. The other thing that scares me about this trial is that it was done in 2010, and no one has followed it up since. So I don't know how reliable these studies are. So honestly, after looking at the trial, I'd be willing to suggest it for patients. I don't think there's much to lose. There's no side effects. So another thing people are trying is something called bacterial interference. And when I was a resident in the mid-2000s, this was really, really big in urology. So the theory is that you colonize people's bladder with a strain of bacteria that isn't virulent. It's not going to cause a urinary tract infection. It can bind to the cells, but it's not going to invade the cells of the bladder, and it's not going to create a problem. So they occupy the bladder. They outcompete other bacteria that might want to set up shop and cause problems for you. So here's how it works. First, you have to grow up the bacteria in the laboratory. Then they can be diluted and kept in a refrigerator for 72 hours, no big deal. Then the patients have to have a 7-day course of antibiotics to have their bladder completely sterilized before they start trying to introduce these new bacteria. So then there's kind of a place for them to grow, and there's not other bacteria trying to outcompete them. So you finish your antibiotics 2 to 3 days prior, and then you start trying to set up colonization. You do this by putting bacteria in the bladder and allowing it to sit for 1 hour, and you do this twice daily for 3 consecutive days. So this isn't going to be the simplest thing for people to do if it actually worked. Almost all the trials were done with patients admitted to rehab centers, and all this was done by nurses while it was going on. For this to be set up commercially, it would take some time and some doing, but it could be done, obviously. Then they tested for people for colonization. If they didn't set up, if the bacteria they were trying to put in didn't set up colonization, then you have to repeat the whole process. So a lot of labor going in to try to put the stuff in your bladder, and it doesn't always set up shop. So most of these trials, after 3 failed cycles, they just gave up. They said, we are not going to get this patient colonized. So this is one of the more recent clinical trials that was done. It was in 2011. They had 45 patients who they were trying to inoculate with these bacteria. 17% or 17 patients, so about a third, got colonized. About 25% of people are successful with each attempt. So that's a lot of work only to get 1 out of 4 patients set up with bacterial colonization. So that hasn't helped this technology, that it's very difficult to set this up. However, if you look at the rates, and these are spinal cord injury patients that they're studying, if you look at the rate of urinary tract infections, people did really well. So of the people that got colonized, they only had 29% had infections within the 6-month study period, whereas those who did not get colonized, 70% had a urinary tract infection within those 6 months. So a huge difference between the two groups. There were no infections from the actual E. coli that they were trying to colonize people with. So it didn't somehow change itself and start causing problems, which is good news. However, the mean duration, even if they were able to set up colonization with this particular bacteria, the mean amount of months that it actually stayed in your system was 5 months, and then you'd have to start the whole process over again. So that's not super great. So we have trouble setting it up, and we have trouble making it stay there, which isn't helpful. So people have talked about, well, why don't we just coat catheters with these bacteria, and every time the patient catheterizes themselves, they're going to set up a new colonization in their bladder, and at some point, if you're doing it 4, 5, 6 times a day, you're going to set up this colonization. Well, people are kind of working on this, but it hasn't really come to fruition yet, and I haven't seen any trials where people have actually done it, but I kind of have my eyes and ears open after preparing this talk, because it seems like a better idea than what everyone else was going through in these other trials, and if it actually did work, it might be kind of cool. So in the end, not a lot of great news or treatments exist. I don't have a magic bullet for everyone to say, this will cure you, this will make sure you never get another urinary tract infection. I will say, however, that not all is doom and gloom. Generally, urinary tract infections are treatable. They're not overwhelmingly common in the spinal cord injury population, meaning I'm not getting tons of people coming to my clinic who are being treated every month for a urinary tract infection. I feel for the most part, most of my patients are getting 1, 2 symptomatic infections per year. They're not building up huge antibiotic resistance with their treatment of their urinary tract infections. And most of them can manage this quite well, and while it's a little nuisance when it happens, it's not like the end of the world. It's not like they've developed cancer and they're going to die of it. What do I expect? So these are kind of my pros. So I've been doing this for 4 years on my own, trying to treat patients in the rehab clinic over at Santa Clara Valley Medical Center, and here's the things I figured out. I expect patients to get 1 or 2 infections a year. In fact, I tell people when I start them on intermittent catheterization, if I'm changing them from some other mode of bladder management, I expect you to get 1 or 2 infections a year. That's the price of business. It'll keep your kidneys safe. Your kidneys will not fail over time. Generally, they'll keep you continent. It's kind of the gold standard. You have much less risk of bladder cancer, or I'm sorry, not bladder, please forget I said that, bladder stones if you're doing intermittent catheterization compared to a chronic indwelling catheter. But some people need a chronic indwelling catheter because their hands just don't work, or there's other factors that go into play. But even with an indwelling catheter all the time, I still expect you to get 1 or 2 infections a year. Most of my patients are doing really well, and I seem to find that the farther patients get out into their lifetime of whatever bladder management they have, they kind of just get better year after year after year. I don't have most people that are doing it 15, 20, 25 years who are just getting infections all the time. It's the people that are first injured as they're kind of working their way, trying to figure out what's an infection, what's not, what's your bowels, what's constipation, what's autonomic dysreflexia, is this a urinary tract infection, is it not? I tend to find that the farther people get out, the smarter they get, because they just learn how to deal with their problems, and they start to understand their body more and more over time. I also will say, I have some people who get no infections. I have people that are 30 years in. I don't know, maybe I had one when I got started doing this, and I haven't had one since. So there's a lot of people out there who are doing fantastic. But that's not the total norm either. So I think if you're having 4 or more infections a year, you should probably see a urologist and just make sure that we're not missing something that's drastically obvious. Do you have a stone? Are you drinking too much? Are you not cathing enough? Is your bladder horribly spastic and overactive? Even if you're not leaking, is it setting you up in some sort of way for this happening? A lot of times I end up doing the whole workup and we don't find anything. But about 25 to 40% of the time, I find something that I think we can actually modify with that patient's current habits. I also say don't treat just because the urine is cloudy. I hate when I hear this from patients. What are your symptoms of UTI? Well, I get cloudy urine. Did you have a fever? No. Did you have incontinence? No. Did you feel awful? No. Did it affect your life in any way, shape, or form? No. What happens, I just tell people when this happens, drink more water. You can generally flush it out between drinking a little bit more fluid and just catheterizing a little bit more. I have so many patients that I've convinced, when it's cloudy, just drink a little bit more fluid, see what happens. We'll treat you. If it doesn't get better, you start having a fever, you start feeling lousy in 3 or 4 days. Most of the time, I don't hear back from those patients because they end up doing well. And I check their charts just to make sure they weren't going somewhere else and getting treatment from some other doctor. And they're really not. So I tend to think just treating for cloudy is a bad idea. If you're feeling awful during cloudy, well, that's a good reason to get treated because then you probably have something. But a lot of patients can just manage this by drinking more fluid. Sometimes the urine's just cloudy because you're a little dehydrated. You know, my urine's a little bit cloudy after I do surgery all day and I don't drink anything and I've been operating for 8 hours and then I go pee. It's pretty yellow, it's kind of cloudy. It may not be cloudy in the manner that patients are telling me about when they're talking about their cloudy urine, but, you know, concentrated urine doesn't look as normal as dilute urine. Don't treat just because the urine smells. Urine smells. And it's okay. If it's not harming you and it's just a smell, I usually tell people, I don't think you should treat just for that. Again, I like to treat for true symptoms. I do treat if you have cloudy urine, smelly urine, and you have new onset incontinence that just seems to be out of the blue. I mean, that can be a UTI that's causing that. If we treat the UTI and it gets better and you don't have any more incontinence after that, well, that was probably what was causing it. If I treat your urinary tract infection and you just continue to have incontinence, well, maybe your bladder has changed for the worse or something else is going on to cause that. If you have cloudy urine, smelly urine, and you have a fever, that's a pretty good reason, unless you have some horrible hacking cough or there's green phlegm coming out of your nose. If the most likely source is probably urinary tract infection, and we should treat that. If you're just feeling horrible and you can't find any other good reason, well, yeah, a course of antibiotics might be indicated. But if you're still feeling lousy at the end of your course of antibiotics and your bacteria was sensitive to the drug you were on, let's start looking elsewhere. Let's not just keep banging our heads against the wall for something that's not working. So, and just because certain treatments that I've kind of documented here don't work for the population at large doesn't mean I won't try them. I put people on Irrigan all the time because I think it can help. Just because it doesn't decrease your risk of bacteria in the bladder doesn't mean it can't decrease your risk of symptomatic infection. Those are two separate issues. And I'm still of the opinion that it's worth trying because there's not a lot to lose. There's very few side effects. And it makes the patient feel like it fixes their problem and they stop coming to me for those frequent symptomatic urinary tract infection where they're getting, big-time antibiotics, sometimes PICC lines for these things, but then it's worth doing, and I think it can be helpful. And there's some data out there that suggests that sometimes it changes the type of bacteria in your urine, and it can be a bacteria that's more friendly and not so difficult to treat in the future. So it can have some effects that are beyond just bacteria being in your urine. I do prescribe methenamine and vitamin C because, again, I don't think you have much to lose, and if it helps, it helps. There are certain people that these medicines really do help. It just doesn't help everyone, and we can't always show it in these studies, but it can work. So it's always worth a try. Methenamine itself has very few side effects other than some GI upset for people, but it's not an antibiotic. It doesn't create resistance. I think it's a fine thing to try. I do prescribe prophylactic antibiotics at times. I have some people where things are just spiraling out of control, and we've got to get things under control for a while because they're miserable. And in those situations, prophylactic antibiotics is fine. I don't love to put people on prophylactic antibiotics for the rest of their life, for the reasons I suggested before. But there are a number of patients who've been treated for 30 years with prophylactic antibiotics. They're doing great. They were having some issue at some point. They've been doing fine since. They're happy. I'm not going to take you off your prophylactic antibiotic. But if you come see me as a new patient and we're just starting all this workup, it's one of the last things I'm going to do. It used to be the default back in the 90s and early 2000s and 80s to do these types of things. But we're starting to realize that they have their own problems as well, and they're not always the best thing to do. I also feel that emerging antibiotic resistance in the population at large, it's getting worse and worse. We're running out of antibiotics for a lot of people. There are reports of bacteria that are resistant to every antibiotic out there, and it's a scary thought. But there are people who at some point I'm not going to be able to treat for whatever ails them. There will be no more drugs for those. And when those superbugs happen, it's going to be a real problem. And treating everyone for the last 30, 40 years with antibiotics for everything that ails them, whether it needed it or not, it's starting to create a problem. And unless drug companies are able to create new classes of antibiotics which are not happening at a very fast rate. The bacteria are getting resistant a lot faster than we're making new antibiotics. We're going to be in real trouble as just a population overall. So I'm trying not to make the situation worse. I'm trying to do my part, though it's difficult sometimes. I tell people to try Cranberry tabs if they want. You know, if you find something that works and you think it works and it's not costing you $1,000 a month, try it. It can't hurt, you know. I don't think these things hurt unless they hurt your wallet. After reading, you know, that study on D-Mannose, I might try it. I might start telling people to try it. I don't see a real downside to trying something new, and if it works for you, it works for you. Lastly, I'm always willing to admit I'm wrong about something. You know, people always look at you like, oh, your doctor, he thinks he knows what he's talking about all the time. I will freely admit, there are a lot of times I have no idea what I'm talking about. I make an educated guess. I try to do my best for patients, but I'm not always 100% right. My crystal ball broke many years ago, and I just cannot foresee the future for a lot of people. So, especially as a surgeon, it's a humbling business. I do all sorts of things. I think I did a perfect operation, and then a week later, there's a problem. And who foresaw that coming? I would have bet you $1 million they wouldn't have that complication, but they do. So I'm humbled on a kind of regular basis by things that happen to people. So I always tell people, just because I say something doesn't mean that's the exact way it should be. So take everything I say with just a bit of a grain of salt. And lastly, like I said, medicine is more of an art than a science at times. There are things that we just have trouble studying. There are things we don't have great data. So I try to use my best judgment. It may not always be right, but I'm trying. And I always say I learn a bit more every day with all my patients who are spinal cord injury, MS, other neurologic issues. You know, a lot of the stuff I do is not in books. It's you learn by experience, and every patient I have teaches me something in one way, shape, or form. I'm incredibly grateful for that. I enjoy taking care of patients with spinal cord injury. I enjoy helping them with problems that other doctors have no idea. I enjoy taking that patient who's been mismanaged by 1,000 other doctors and fixing their problem with a few simple moves. It's always kind of gratifying to say, I fixed that and nobody else could. It's kind of cool. And the spinal cord injury population is a population that's very poorly understood by a lot of doctors, and the things that are done in the name of good medicine are not always the smartest things in the world. And I'm always trying to educate people out there, but they kind of overwhelm me sometimes with the sheer numbers of people that don't understand your guys' condition very well and are not able to help you in the way I think they should.
Last line I have an idea. Are you a writer?
I am a writer. I actually do publish research. I actually do publish spinal cord injury research. So in the last 3 years, Dr. Shem and I over at Valley Medical Center, we published one paper on just the epidemiology of hand function in people with spinal cord injury, just how many people have good enough hand function just to catheterize themselves. I see all kinds of people that are sent out of Valley Medical Center and other institutions told, oh yeah, you should do intermittent catheterization. Well, they have no way of catheterizing themselves. They can't even hold a catheter in their hands. How are they going to do this long term for another 30, 40, 50 years on their own and have it be socially and functionally doable? So we've written a paper on that. We've written another paper on hand function and how it pertains to what people end up actually picking for their bladder management at a year down the road. We found that, you know, hand function seems to be the largest predictor. We're in the process of writing a grant to test our hypothesis and then test a ton of other social factors that may kind of dictate what people do. And I've actually just written a recent paper with a resident that we're going to be submitting soon about the risk of febrile urinary tract infections after ureteroscopy for stones. It's much higher in patients with neurogenic bladder, spinal cord injury, MS, stroke, other things. And we were trying to figure out why that is. And we think most of it is not due to the fact that you are labeled as a neurogenic bladder, but rather that you're chronically colonized and we're taking a scope up with high pressure to look at these stones because it's a small scope in a tiny space and you need high pressure irrigation to see, and we think we're just pushing bacteria into the bloodstream. So we do work on things. I do write. I don't have enough time to write. If you'd like to write the administration at Valley Medical Center to give me a day off so I can write more, I'd be more than happy. But in the meantime, I probably have a lot of patients who would be upset that I'm not seeing them on a regular basis. But good question. Yes.
So then, are there reliable home test kits for UTI?
So the question is, reliable home test kits for UTI? No. The test kits we even have in the hospital are no good. So I don't think the ones at home are very good. Like I said, all those home test kits are basically looking at white blood cells in the urine. White blood cells in the urine are very common if you have an indwelling catheter. They're common if you do intermittent catheterization. I think they're highly unreliable. I think patients look at those with urogenic bladders and they start getting treated all the time for things that they shouldn't be treated for. And a lot of times those aren't cultures. So we don't even know if a bacteria actually grow because people just start taking antibiotics. They never actually get a test. And when they don't get better, was it because they were resistant to that antibiotic? Was it because they never had an infection in the first place or any bacteria in their urine? Or is it something else? And I find that they tend to muck up the situation a lot, and they don't really help me most of the time if there's treatment failures. If they work and you're using them sparingly, maybe it's okay. If you're just testing your urine randomly, you're going to start treating yourself for infections on the best day of your life and you feel like $1 million.
They'll give you a false positive, they'll give you a false negative.
They will do both. More often than not, they will give you a false positive, but false negatives can occur, but not nearly as often. So the question is, are those test kits, can you, I say they're not great from a sensitivity standpoint, but will they give you false positives? They will at times, but they will not always. They're much more reliable from I don't have a urinary tract infection than I do have a urinary tract infection. But most people don't really want to know, do I not have a urinary tract infection? Everyone wants to know, do I have a urinary tract infection? And the incidence of bacteria in the urine is so high, and the incidence of white cells in the urine is so high, that more often than not, you're not going to be able to prove you don't have an infection, but you're going to think maybe you do have an infection. So, I don't know if that makes sense. Okay. Yes?
Do you have much experience with patients who are on prophylactic antibiotics for other conditions and how it would affect their urinary health?
So the question is, do prophylactic antibiotics for other conditions, can it help their urinary health? I don't have a ton because there are not a lot of patients that are kept on prophylactic antibiotics that are antibiotics that generally affect the organisms that cause chronic UTIs or urinary tract infections. So a lot of people who are on chronic antibiotics are generally on things that cover gram-positive bacteria, so that they have like heart stents or something, they're trying to prevent infections. But the most common things that affect heart stents are gram-positive, which is a type of organism. But the majority of urinary tract infections are caused by gram-negative organisms, and those antibiotics have no effect on that particular organism. So in my experience, there are not too many people I have that are on antibiotics for other reasons that help their urinary tract infections. But just because the most of the people I see who are on chronic antibiotics are on for those particular indications, and it really doesn't help that particular situation. I would never pick those antibiotics for someone.
I ask because I'm taking Methenamine
Okay.
Following the severe osteomyelitis.
Mm-hmm.
And I noticed that my urine is cleaned up, and actually in almost 3 years I've
Yeah.
had zero symptomatic.
So the question is, he's taking Augmentin, and he's found that it works much better. His urine's been much clearer, no infections in the last 3 years, or maybe one. It's certainly the case. I mean, Augmentin is a drug that you would actually use to treat urinary tract infections. So as a prophylactic antibiotic, it wouldn't be my first choice because it's kind of a big gun if you were going to be picking it for prophylaxis just for urinary tract infections. But when you're dealing with osteomyelitis, yes, it can help. Is it good for the urinary tract infections? Well, I think you take it as a byproduct of it's helping with your chronic bone infection, and I love good outcomes or good side effects. So this is a good side effect for you.
Long-term risk.
Long-term risk with Augmentin is only that, you start getting urinary tract infections in the future that are resistant to Augmentin or ampicillin, or because it's part of the penicillin class of families. Yeah, it'll be resistant. If it's resistant to Augmentin, it's going to be resistant to amoxicillin, penicillins in general. But it doesn't mean that you've killed all your other options. There's tons of other options. But I mean, again, I wouldn't advocate it as a way to prevent UTIs, but when you're taking it for another reason and you get this nice serendipitous good side effect, I take it for what it is. Sounds like a good thing. You've turned a negative into a positive. I like the way you're looking at it. Yes.
If you take an antibiotic once or twice a year, what's the risk of developing resistance?
So the question is, what's the risk of developing resistance if you're only taking an antibiotic once or twice a year? And it's pretty small. Generally, after a course of antibiotics, it takes the gut, which is the source of most of the bugs that cause urinary tract infections. They're usually fecal organisms. And that doesn't mean you're not keeping yourself clean. That doesn't mean you're not taking care of yourself. They're just kind of all over our body. They're all over our perineum. They're all over our genitals, and they tend to find their way into the bladder. But generally, after 6 to 8 weeks, generally the body resets itself and goes back to its old equilibrium. So in that first 6 weeks, after a course of antibiotics, you may get something that's resistant to what you took before in that previous 6 weeks, or you might find some new bacteria that's taken hold of the area because everything else good was taken out by that antibiotic. But generally about 3 months out, you're pretty okay. That's part of my reason for, I feel like if you're having more than 3 or 4 infections a year, I start to get concerned. But I think less than that, I don't really get too concerned about that. I feel like that's kind of the cost of business, and I don't think that's a bad thing. And honestly, it's pretty normal.
You didn't mention probiotics. Do you recommend?
Yeah, so the other question is, I didn't mention probiotics. There's no, and I forgot to put that in my slides, and I apologize. There's no data to suggest that probiotics changes the risk of urinary tract infection in the spinal cord injury population or in the general population overall. So probiotics are big because everybody wants to take probiotics. They're in all the yogurt in the stores, and they make all these pills that are probiotics. There's really no data behind it. A lot of people take it because they feel like it makes their bowel habits better, and that's, I think, why it's really caught hold in a lot of the grocery stores and drugstores. And then there's this kind of preconceived thought that, yeah, this will grow good bacteria and, I won't get as many urinary tract infections, but I don't think there's any data to support it, specifically in the spinal cord injury population. But again, like I've said before, if you can afford it and you like it and you feel it helps, do it. It's not going to hurt you.
Do you find any benefit of probiotics when people are on a course of antibiotics?
So the question is, do I find that probiotics are helpful when someone's on a course of antibiotics? I haven't really thought about it. I don't put too many people on very long courses of antibiotics, but I generally don't put them on probiotics. I generally hope that they don't get some horrible diarrheal infection, because it does happen to me every once in a while, and it's kind of disconcerting. But I don't know of any data that suggests that probiotics make it better, so I haven't made patients do it. I feel like it's one more just kind of inconvenience for them to tell them they have to eat like 2 or 3 yogurts a day, or go to the GNC and find something that I have no data on to take. I don't really believe in doing that, but I mean, I would certainly, if a patient wanted to do it, I wouldn't have a problem with it.
So on that D-Mannose.
Yes.
That'd be interesting.
Yeah.
Back to, okay, you go to Delaware, you get GNC or whatever.
Yeah.
That's back to the same unregulated, who knows what's really advanced.
Mm-hmm.
So it's kind of a crapshoot.
So the question is, the D-Mannose I was talking about, if you went to a GNC and you started taking it, would it be the same formulation they were using in Croatia? Probably not. You can probably look up the paper and find the manufacturers. I'm sure they'd be happy to sell it to you to take exactly what they were using in Croatia. Is it the same unregulated crapshoot? Yes, it is. And again, I'm not going to totally buy into it until I see a bunch more studies, and then I see a couple companies that are kind of regulated to a certain extent or have good quality control that you can trust in to say it works. But again, the thing that worries me the most about this is that there's been one study in 5 or 6 years, and that study was so overwhelmingly positive that I would think if it was that great, other people would have done the studies, or other people would have done it, or I would have heard about it before preparing for this talk, or just having patients tell me about it. So I'm kind of a skeptic on certain things. I believe in voodoo to a certain degree, and I don't always trust that researchers out there are using sound methods or that the results are as good as they say. I've seen a lot of things out there that people have touted, hey, this is fantastic for this condition, and then people can't replicate the results, and then you start to wonder. Yes, sir.
I have a Hydrophilic Catheters. Over time, there's really no pressure on the bladder.
Mm-hmm.
And a shrunken bladder, a risk for bacteria being pushed up.
So the question is, with an indwelling catheter, your bladder will shrink a little over time. We see that in a lot of patients. Is that a risk factor for shooting bacteria up in the kidneys? Not good capacity, not good compliance. I typically don't think so, because if the pressures are really going to push, they're going to actually preferentially go down your catheter. Your catheter has much less resistance than your kidneys do. Your ureters and your kidneys have a built-in mechanism where it actually takes quite a bit of pressure to push urine or bacteria back up into the kidneys. Whoever made human beings made that one of the things that we have, that we have some protection. So the risk of an infection in the bladder going up in the kidneys is actually pretty rare, because there's defense mechanisms built in. You still have those defense mechanisms. We all have them to a certain degree. So unless your suprapubic or Foley catheter gets blocked or clamped off for multiple hours or days, then it's a risk. But if it's freely draining, it should not be any more risk than anyone else.
Hi, everyone. If you have any questions...
But we sometimes get patients who are catheter encrusted for 12 hours, they were asleep, they didn't notice, they wake up, they're sick because that happened, nothing drained for 12 hours, then yeah, you can get really sick when that happens.
So basically you don't recommend taking meds to relax the bladder. So
the question is, do I recommend medicine to relax the bladder? It's highly debated in spinal cord injury whether that's necessary in people with chronic indwelling catheters. Personally, I don't do it for most people. I don't see the point. It just seems to be a medicine without any discernible benefit as far as I can tell. There are no studies to suggest it's helpful. If people start having leakage from below, they have their suprapubic, but all of a sudden they're starting to leak from below, the first thing we do is make sure somebody didn't blow up their balloon to 25 or 30 cc's and just take up their entire bladder capacity, which I've found several times in the last couple of months. But if that isn't the case, then yeah, I'll start somebody on some sort of bladder relaxant at that point. But I don't do it as a general matter of practice. I know there are other doctors out there, you have this it's going to shrink your bladder, you should be on this medicine to relax your bladder. I don't really know what the difference is.
I just thought, one reason is getting more and more difficult when you insert the catheter in the bladder.
Okay.
It's too much pushing against the wall.
So the question is, if your bladder's shrunken up enough that it's hard to get a suprapubic tube in, well, that's a good reason, but that has nothing to do with urinary tract infections, why I would do it. And again, it's just one of those potential complications of a long-standing indwelling catheter. That's why CIC is considered a gold standard for management, but it's not practical for everyone, and I think the sooner the medical community figures that out, the better it's going to be for patients. We need to try to keep people on intermittent cath when it's feasible from a hand standpoint and from every other standpoint. If you're leaking in between and that's why you want to switch to an indwelling catheter, well, it's my job to get you dry in between, and I can if you give me enough of a chance. I have enough tools out there to get someone not leaking. But if you don't have hand function, you can't catheterize yourself, well, then yeah. It's not a good option to tell you to do intermittent cath. That's just the dumbest thing I've ever heard of. It makes you completely dependent on someone else, and a lot of people don't have someone there every second of their life to take care of them. I mean, there's something to be said for independence.
So in terms of, I went through that, they said, okay, make sure you go see your urologist like once a year. And I'm sorry, that's probably a little bit over. But, realistically, as spinal cord patient, how often should you see your urologist and have a workup done?
So the question is, after you have your spinal cord injury, a lot of people are told, go see your urologist once a year to follow up. Is that reasonable? Is it a waste of your time? What is the kind of regular schedule that you should go see someone? So I usually tell people, look, if you're on some sort of established bladder program and you're just sailing along, you don't need to see me. There's no point in seeing me. I'm not fixing anything. I'm not doing anything. I feel like everyone that has a spinal cord injury should get an ultrasound of their kidneys and bladders every 12 to 18 months. We should survey for stones. We should survey for hydronephrosis or something's wrong that's kind of silently moving along that we don't know about. I kind of feel like if you have new onset incontinence and, you know, regular simple measures aren't fixing that up, then you should come see me. Who should you get your ultrasound from? Well, your primary care physician can order an ultrasound once a year. They can call me if there's a problem. They can send you to see me if there's a problem. That seems like a much better use of your time than seeing a specialist for no complaint. I feel like I'm kind of busy enough. I don't need to see people who don't have problems. I need to see the people that have issues that need addressed. I just need other people out there getting the routine stuff that people need to make sure everything's okay. So what I tell people is, again, renal bladder ultrasound every 12 to 18 months. You should probably have your kidney, you know, checked once a year with just a simple lab, a Chem7, just to look at your creatinine level. Just make sure it's not creeping up some sort of medical issue with the kidney, some sort of anatomic obstruction in the kidney. Other than that, I don't think I do need to see you on a regular basis. I agree with your standpoint, you know. See me when there's a problem. Have someone else, you know, who sees you for everything else. Kind of get that as part of a routine surveillance and part of, you know, everybody gets a colonoscopy every 10 years. Everybody gets, you know, a physical once a year. Well, get your ultrasound every year as part of your physical. You know, that should be done. But more than that, I don't think it's necessary. Yes?
I've developed kidney stones. I'm just curious how related that is to the SCI.
How what? I'm sorry.
Huh?
How common? Okay, so the, yeah.
Any correlation to bacteria?
Okay. So the question is, how common are kidney stones in the spinal cord injury population, and how related are they to bacteria? Most kidney stones are not related to bacteria. It's only the really horrible kidney stones that are related to bacteria. So that one I showed you was like one of those horrible kidney stones. It's filling up the entire kidney, essentially. That's a bad stone, and that's caused by bacteria. Most stones are not caused by bacteria. What's the rate of kidney stones in the spinal cord population? It kind of depends. Different spinal cord injuries cause different amounts of bone demineralization. I always tell people, once you have a spinal cord injury, you're kind of like an astronaut to a certain degree. There are certain muscles and limbs you're not using anymore. So it's like going to space. And they found all these astronauts when NASA sent them to space, and they weren't using their legs because they're in a weightless environment, and their arms weren't really doing much because there's not even gravity up there. They find that their muscles atrophy and their bones start demineralizing because the body's like, oh, I don't really need these that much, so they don't need to be so strong. So when that calcium all demineralizes from the bone, the way it comes out is through your kidneys. And if you have high levels of calcium flowing through the kidneys all the time, it increases your risk of forming a stone. So most spinal cord injury stones are a result of just being immobile in certain limbs and those bones demineralizing over time. There's also some patients with spinal cord injury who are they just don't drink a lot of fluid. They do it for continence reasons, or they do it for other reasons. And not drinking even, you know, threshold amounts of fluid increase that supersaturation of the chemicals that can form stones in the urine, and it can increase your risk. So we really tell people your goal should be, you know, 1.5 to 2 liters of urine a day. If you're making 2.5, 3, that's fine, but you know, your goal should be at least 1,500 mLs of urine per day minimum. But there are certain people who are at high risk, and that's part of the reason I like to get over the bladder ultrasound every 12 to 18 months, because a lot of these things they form very silently. Most people don't know they have a kidney stone until they have a real big issue from their kidney stone. So in a population that the risk is higher, and I don't know if I can quote you a specific number, I kind of feel like we should just stay on top of those things.
If you do have an X-ray and you have a stone, and the doctor says, well, we'll see if it grows, and if it doesn't grow, and it doesn't cause you to have infection, is it okay just to leave it there?
Yeah. So the question is, if you do have a stone and the doctor tells you just keep an eye on it because it's not really growing over time, it's not causing you problems. Yeah, there are some patients I don't do anything about their stones. We just know they're there and they're not really causing issues. Usually stones in the bladder I want to get rid of. Those are just going to get bigger and bigger and bigger. There's no way, shape, or form about that. That will get worse over time. The kidney stones, I mean, it depends. You know, there are certain places kidney stones can be and they're probably not going to cause a problem. There's other places they're going to be, and, you know, it can be very inconvenient at times when kidney stones decide to fall into the ureter, block you up, and cause a problem. I have people who are going overseas a lot, and they're potentially going to be in a third world country when really bad things happen, well, then we should probably get rid of that stone before it's a problem. If you're around Santa Clara all the time and you have access to really great medical care and you don't really feel like having an operation that you may or may not need, well, then that's a different reason, and I think that's okay. Again, everything depends on situations a lot of times, and the specific patient goals, specific patient risks, and things like that. So I'm not sure that's a perfect answer to your question, but I don't treat every single stone.
You talked about bladder stones, kidney stones, gallstones fall into this.
So the question is, do gallstones fall into the same genitourinary things that we're talking about, bladder stones and kidney stones? And gallstones are no. They're part of the gastrointestinal system. They're in your gallbladder. They're not connected to the same pipes. So it's a different set of surgeons that work on those pipes. Those are the general surgeons, the urologists, different pipes, different plumbers. We're all kind of plumbers, the surgeons. Vascular surgeons are plumbers, urologists are plumbers, general surgeons to an extent are plumbers. So not sure about gynecologists.
The plumbers make more money.
Sometimes. But that also means you're on call a lot. People find the worst times to get sick sometimes. Yes. Anyone else?
No more questions? There's no questions on persistence. Thank you.
Okay. Well, again, I'm glad we got to talk about a subject that everyone's interested in. Thank you guys. I appreciate the turnout. No, actually, the QA last time, there was a lot of QA, but it was about nothing I talked about. It was all about these particular subjects. These are the things I found out. I'm like, okay, this is what people who are out for a while, this is what they care about. They don't really care about bladder reconstruction. They found their way by the time they start coming to these meetings, and they don't really need to hear about all the great things I can do to your bladder. They want to hear about how to prevent all the silly things that bother them, not silly things, but all the chronic things that can bother them that can cause issues, not the life-threatening things, it's all the little things that are nuisances in their life.
One final question. One issue that I've read in the internet regarding Hydrophilic Catheters is how irritation to bladder, so you are at more increased risk of developing bladder cancer.
Okay, I knew I was going to get this question.
A lot of doctors recommend you get cystoscopy.
Okay. So the question is, if you have an indwelling catheter, there's a lot of people out there that say it causes irritation, it can increase your risk of bladder cancer, and you should have surveillance cystoscopy to make sure you don't have cancer. So the original studies that came out in the 1990s about this subject were very scary, actually, for a lot of people, because they found a very high risk of bladder cancer. And if I was a spinal cord injury patient with an indwelling catheter, I would have been really concerned. Since that time, they haven't really been able to replicate those numbers to any great degree. There is a finite increased risk of bladder cancer with an indwelling catheter. It is not substantially higher than the general population, and the bladder cancer in the general population is a rare condition. So even in spinal cord injury patients with an indwelling catheter, bladder cancer is a very rare condition. If I were to scope everyone, do a cystoscopy, look inside everyone's bladder who had a chronic indwelling catheter, who had spinal cord injury or some other neurologic problem with their bladder, who had an indwelling catheter, that's all I would do all day, every single day, 5 days a week, because there's a lot of people with indwelling catheters. So, and the number of people I would help in a given year, I could probably count on less than 2 hands. It would be maybe 3 or 4 people, and most of the time I wouldn't be finding cancer. I'd find some little stone in their bladder or something and fish it out. So they've done trials of people they think are high risk for bladder cancer, smokers with indwelling catheters, who you would think are the highest risk to get bladder cancers. And those studies, using fairly significant numbers of patients with urologists who are reputable and know what they're doing, have not been able to show that routine surveillance cystoscopy decreases the risk of bladder cancer recurrence, or they find it earlier in those patients. In fact, in a couple of those trials, the only bladder cancers they found were people that had had cystoscopy, or someone looked in their bladder 4 or 5 months earlier, and then they showed up with the bladder cancer 4 or 5 months later. There's also a really nice article written in Journal of Urology looking at just the sheer economics of it, and it is highly cost ineffective as a screening test to do cystoscopy in everyone's screening for bladder cancer. It's on the order of like just ludicrousness. Like if you were a business, you would never pay for that to be done because it makes no sense from a financial standpoint. Your ability to find the cancer, the incidence of that cancer, and the impact you will have on that patient's life. So I do not do routine surveillance. And when I came to Santa Clara Valley Medical Center, that was a big deal because everyone before me was doing it based on old data. And I came in and said, well, I think this is a silly practice. I don't think it's cost effective. Since then, all these studies, a couple of the studies have come out that show it's highly cost ineffective, and the big minds in urology have all started arguing against the practice of surveillance cystoscopy. But I do tell people, if you start to have blood in your urine, that's what would trigger a cystoscopy and a workup in someone who's able-bodied without a spinal cord injury to get a workup from a urologist. It's not normal to have blood in your urine. So I tell people, if you start to have a lot of blood in your urine, and it's not just like a one-day thing that went away and didn't come back for another year, but you're having it on a routine basis, you need to see a urologist because you are at a slightly increased risk. I mean, there's no way to change it, but as I tell a lot of my patients, you know, it's kind of a cost of business. I don't know what else we would do to manage your bladder other than an indwelling catheter in certain situations. And it does increase the risk to a certain degree, but there are just certain risks we all have to assume in life to a certain degree, but we have to be smart about it. When signs and symptoms start to show up, that's when the urologist needs to really look inside. We don't say, it's probably just a tube, don't worry about it. Like, those are the times when we need to look inside the bladder and make sure.
For everybody, how treatable is bladder cancer?
What's that?
How treatable is bladder cancer?
I'm sorry, you can't hear.
How treatable is bladder cancer?
How treatable is bladder cancer? So the question is, how treatable is bladder cancer? That's a whole talk unto itself. So there are types of bladder cancer which are very low grade, very treatable with resection. There are some types of bladder cancer that are kind of intermediate treatable. We treat them with resection, and then we do some vesicle or intra-bladder chemotherapy. And there are some that are serious enough that we need to take out your bladder. And there are some that by the time we find them, they are metastatic and they're all over your body and they're going to kill you. And I've had, during my time at Santa Clara Valley Medical Center, I've had one patient die of metastatic bladder cancer. And by the time we found it, his whole bladder was completely filled with cancer and it had spread throughout his entire body. He'd been having symptoms for 6 to 9 months and hadn't really followed up on those. But it was one of the worst things I've been associated with my spinal cord injury patients is kind of watching this gentleman fairly rapidly from the time of diagnosis to within a month and a half die of his cancer. It was that bad when I saw it. So it can run the gamut. It's not a cancer that I treat trivially. It's a big deal. So I do tell my patients, when you're having symptoms and it's not just, you know, somebody yanked on my catheter and I bled for a day or two, you know, it was associated with an infection and I treated it and it didn't come back ever again. But if you're having repeat hematuria, we need to consider looking at it just for everyone's peace of mind. It's a simple test to look at to go inside someone's bladder and look. I don't advocate it for doing everyone for screening, but if there are indications for doing it, we should definitely do it. I do it at least once every month, once every other month for patients. I mean, I just did one on Monday for a guy I was kind of worried about based on a symptom. Luckily, he didn't have anything. He just had kind of a bad infection, but it wasn't entirely clear from the history, and we needed to figure it out. Okay.
Thank you.
Thank you, guys.